Good morning, everyone. My name is John McGinniss. I'm from the University of Pennsylvania. I wanted to thank the organizers for putting together this wonderful program. Today I'm honored to present on our team's work on the lung microbiome in lung transplant and the role in primary graft dysfunction. So first I wanted to thank the team, specifically the Coleman and the Bushman labs at Penn, and many others who made this work possible. To start, primary graft dysfunction is acute lung injury that happens within the first 72 hours of lung transplant. And it's graded based on the P to F ratio, which is a marker of the severity of hypoxemia, with lower ratios meaning higher levels of oxygen support are needed to maintain a safe level of oxygen in the blood. And the other degree of severity is chest X-ray. And what we know about this is that those that develop severe PGD at the time of lung transplant have worse short and long-term outcomes. Despite the importance of PGD in lung transplant outcomes, relatively little is known about the pathophysiology. It is known that there is a degree of ischemia-reperfusion injury by definition in lung transplant, and this seems to be an important contributor. The allograft can be primed. Some tissue-resident macrophages and other resident cells seem to be contributors to inflammation. And then also after implantation, neutrophilic infiltration helps mediate the acute lung injury. The aims of our study are to understand how the lung microbiome might be contributing to this process of acute lung injury at the time of transplant. So what we did was we had lavage samples from the donor lung right before it was explanted, and then from the recipient lung right after the lung is reimplanted in the recipient. From these samples, we performed 16S sequencing, and additionally from the recipient sample, we performed ELISA for pepsin, and then a broad 41-plex assay looking at host response and inflammation. Then each of these subjects are followed for the first 72 hours after transplant. On each day, they're assigned a score of 0, which is no PGD, to 3, which is severe PGD on each day. And our main finding is that in the recipients, there was a discrimination in the lung microbiome between those that had severe PGD3 on each day and those that had PGD0 on each day. Those here in this weighted unifrac plot, you could see that those that developed severe PGD3 had a lung microbiome characterized by more Prevotella or Neisseria and less Streptococcus or staph. And when we interrogated it further, it really seemed that Prevotella and Streptococcus stood out, and that those that had high Prevotella and low strep had a high risk of primary graft dysfunction. When we further looked into this, and the plot on the right is creating a Prevotella to Streptococcus ratio, and that there seems to be a stepwise increase between those that had no inflammation, some inflammation, and severe inflammation after lung transplant. And then further, trying to understand this mechanism, we measured pepsin, which is a gastric enzyme that is normally not found in the lung and may be a marker of aspiration. And we found on the left, we could see that independent of other markers, that pepsin was elevated in the lungs of those subjects that developed primary graft dysfunction. And further, the pepsin levels correlated with the microbiome, and specifically those samples that had high Prevotella also seemed to have high pepsin. Our next step was to assess the host response and inflammation through this 41-plex assay. And on the left, this is a principal components analysis looking at basically an overview of the type of inflammation that's seen in those that have severe PGD versus no PGD. And those that had more severe PGD were characterized by this hyperinflammatory phenotype. And on the right, these are 12 cytokines out of the 41 that were independently associated with PGD3. And you can see they're kind of broad, differing functions, but sort of all associated with PGD, and all higher levels of these cytokines were associated with PGD. And then, because we had multiple rich layers of data, we did an integrated analysis. Here we're showing the microbiome host-response interactions, and we found some interesting patterns, namely that Prevotella, the taxa that was associated with severe PGD, also associated with severe inflammation. And then conversely, Streptococcus, which was seemingly protective against PGD, had negative correlations to multiple of the cytokines and chemokines that we assayed. So this left us with a working model of during the time of lung transplant, from the donor to the recipient, there may be micro or macro aspiration, which then, depending on the type of microbiome, can, and then if pepsin is present, prime the allograft and having a robust innate immune response, and then PGD and lead to an X-ray like on the top. And contrary, depending on the microbiome type and the absence of pepsin, have a more balanced host response and good clinical outcomes. With that, I will stop, and I'm happy to take any further questions, and want to thank everyone again for allowing me to give this talk.